So Fatni is going to speak about medium depth pills, and we actually have a lot of questions coming to the chat. And you have any question, you are most invited to upload them to the chat. Fatni, please.
So it's a great honor for me always to lecture for our academy, and of course to share this session with Dr. Landau and Dr. Siversen. So today we're going to talk about medium pills. Just a little bit of revision. We know that chemical peeling is a controlled wounding of the epidermis, the dermis, or both for medical and aesthetic improvement by applying a chemical agent. The chemical peels date back to ancient Egyptian times, but the understanding of the science behind the chemical peeling is still evolving. And of course, we will always follow studies that investigate the histologic and long-term effects of peels in order to provide data to support our clinical observations. Chemical peeling is not just an aesthetic procedure, it's evidence-based medicine, and it's a very serious procedure we have to take care of. So this is why it needs a very proper patient selection. What we need for that, we're going to see more details later. But I want to tell you something. Unlike other aesthetic treatments like fillers or Botox, with pills, you are not the only responsible for the treatment. So you have to be sure that you have a good cooperation with your patient. You have to love your patients. This is something that Dr. Landau keeps saying, and now we all know it as a very great lesson. You have to love your patient in order to peel him. So you have to spend some time and give him a thorough consultation. This is very vital. You have to address if the patient has realistic expectations. You have to promise what you can deliver and not promise things that cannot be delivered. So do not promise miracles with superficial pills. You have to obtain information about proper wound care to the patient and the family, especially with medium and deep pills. There will be some kind of disfiguration, and this is something that you have to inform the patient. Sometimes they do not understand to what extent they will look like ugly, but you have to inform them and also the family so that they keep calm post-procedure. So you have to take under consideration the Fitzpatrick skin type, the Glugau scale in order to decide which pill for which patient. Take some photographs. It is very vital because once patients start to deal with cosmetic procedures, they start to discover things on their faces that have never noticed before. So if there are things that will get you into trouble, take some photographs in order to be safe later. And of course, sign an informed consent for medium and deep pills. So what we need in order to make a good patient selection, we have to assess the Fitzpatrick skin type, the eyes and the hair color. The old Fitzpatrick skin type scale now today's means nothing because the populations are mixed. We have to get information about any kind of previous pill reactions. If the patient is pregnant, we have to adjust our treatment. If there is any history of herpes virus, smoking, isotretinoin use, or any kind of occupation. And of course, keep in mind that certain skin types are more reactive due to ethnic, racial backgrounds that are not discussed in the old books. So chemical peels are classified according to their depth to superficial, medium, and deep. And the results, the downtime and the risk of complications increase with the pill depth. So you have to be aware of the chemical agent you are using. You have to decide which concentration. It depends on the duration of the application, the number of passes. Keep in mind that different passes are completely different from covers. So it's another thing pass and another thing the cover. You have to decide which method of application you will use, a gauze, a Q-tip. Of course, again, the skin type and some skin preparation if needed. So here in this picture, you can see where the superficial peels act, and you can see that they go throughout all the epidermis. And then we have the medium pills that go through the papillary dermis and the upper reticular dermis, and of course the deep pills that go even deeper. So the good thing with medium deep pills is that they are single procedures. They have a long-lasting effect. Patients, before giving them an aesthetic procedure, keep saying, "Doctor, how long will it last?" So this is a very long-lasting treatment. It can be combined with the energy-based devices, and the energy-based devices can be replaced by chemical peeling. So you can save for you hundreds of thousands of dollars, and with just $10 or $20, you can have great results. And of course, they're compatible with other treatments also, so we can give our patients combined protocols. You can have tightening with medium pills or not. Maybe we can discuss it later, because some pillars believe that we can have tightening with medium pills, and some others support that only medium pills can give us tightening. So the TCAs are a histological barometer determining the depth. So superficial pills regarding TCA are 10 to 30%, medium 40 to 45%, and then deep pills from 50 and more. And TCA is a very highly water-soluble agent. You have to keep in mind that no patient and no company representative should know more than you about chemical peeling if you decide that you want to become a peeler. So you have to be aware of the pH or the pKa of the agent you are using, because, for example, currently accepted standard preparations for TCA is weight to volume, but there are other preparations such as grams to mLs, or it's weight to weight, or weight to moles. So you have to be aware of how aggressive your agent is, even if you have two solutions with the same concentration, because the depth of the penetration correlates directly to the concentrations. The TCA penetrates slow, and that is why you have to wait at least 5 minutes to assess the frosting, the end point, so that you avoid complications due to overcoating. The most common medium depth pills include the TCA 50%, dry ice and TCA 35 to 50%, Gerstner solution and TCA 35%, the modified phenol formulas, 70% glycolic acid plus 35%, and some phenol preparations. The most famous medium pill formulas are the Brody pill that employs solid dry ice, the Mohide formula, and the Coleman pill. So we have to tell our patient that he's undergoing a very serious procedure, and medium pills are a long story. So by day 3, we have a full thickness epidermal necrosis, dermal inflammatory infiltration, and papillary dermal edema. Then within a week, the epidermis starts to be reepithelialized. And then a month later, there is a regeneration of the collagen, and until day 19, the skin begins to get thicker. So medium depth pills, what is the idea, and why do we need medium depth pills? The idea is the insult of the skin with something prior to the application of the chemical agent, often TCA, in order to enhance the result of the TCA 30%, which is practically not a medium pill, because TCA 50% has a high risk of scarring and pigmentation. Because it's safer. Safer medium pills include solid ice plus 35%, the Gerstner formula, and all these famous formulas. Because phenol is not for everybody and has some risk of hypopigmentation or toxicity. And of course, medium depth pills should not be performed over the face, because all the skin around our body is not that forgiving as the face area. So regarding the Gerstner solution and TCA 35%, which is the Mohide formula, it's a medium depth pill with great results and a very high safety profile. It can be the TCA can follow either solid ice or the Gerstner solution or salicylic acid or even skin sanding. These are other methods. Skin sanding is a very interesting method. You use the sandpaper fixed on a syringe or any other instrument. You have to give your patient an even rubbing on the whole face and more vigorous at areas of higher demand. Some use it dry and some peelers use it wet with normal saline or lidocaine. Some use the peel before the dermasanding and some others after the peel. 400 grit is something that is more recommending, and the end point of the procedure is some bleeding. Cross method is regarded medium depth peel. What we do is we begin with a 70 to 100% TCA placed with a toothpick inside the scars. Be careful not to avoid any overleaking. And then we follow with the 20 or 30% TCA on the whole area. And the results are really great. And of course, medium peels can be a part of segmental peeling procedures because there's no need for operating room or monitoring. And treating 1 or 2 face units with deep peel formulas while applying medium peels are safe and give us great results. What are the indications for medium peels? Photoaged skin, solar erythemas, pigmentary disorders apart from melasma. I believe also that medium peels are not appropriate for melasma. Melasma needs either superficial peels or really deep peels. You can use medium peels when you want some skin tightening, when you have to deal with actinic keratosis, with acne scars, these are all indications that you can have great results. But keep in mind that repeated superficial peels cannot reach the medium or the deep peel results. So decide what you want to do and explain your patient what he has to wait as a result. We have to be honest that the TCA medium peels during the process are painful, so we need thorough ventilation. What I do is either give them some sedation or use my Zimmer from my hair removal device in order to give them a feeling of coolness. Before we peel, again, we have to consider the Glogau scale and the quality of the skin. And there's a lot of controversy about skin preparation. Of course, sunscreen is before and after peel very mandatory. Hydroquinone-based creams, Kliegman-Trilumans, and all these formula are very useful, especially for skin of color or dark skin individuals. Some doctors use mild acid-based products like vitamin C, AHAs, PHAs, and retinoic acid for preparation. What we need and the conclusion that the peelers have come to is that preparation is maybe mandatory for superficial and medium peels, but it's not mandatory for deep peels because you prepare the epidermis and then the skin and then you remove it. The controversy behind the skin preparation is that the patients do not apply evenly the product. So the uneven preparation may lead to an uneven penetration of the chemical agent. Of course, you cannot proceed to peeling before learning how to read the frosting. Keep in mind that salicylic acid gives you a pseudo frosting due to the crystal. It's not a real frosting. And then on the corner layer, we have a powder light frosting, like a cloudy effect. Then we have a speckle white frosting, white frosting with under-like erythema when we go deeper, and then the gray frosting of the really deep peels. What you see in the picture is the frosting that a medium peel can give you. So medium peels are not superficial peels, so they need close follow-ups, especially when your patients have mixed phototypes. You have to be ready to treat any kind of post-inflammatory hyperpigmentation that does not appear day one. You have to wait about 2 or 3 weeks post-peel. Then hydroquinone is life-saving or any other kind of tyrosine inhibiting products. You have to treat it day one from the appearance, before the pigmentation moves deeper. And sometimes, as soon as the erythema has gone, superficial peels like salicylic acid 30% can help you to treat your patient. So the overall complications regarding superficial pills are very low risk. Medium pills run a higher risk of complication, then deep pills have sometimes greater risks. But if you're well trained and you want to have good results, you have to go deeper and deeper. Pitfalls that we have to avoid is that we have to apply them carefully, wait for the frosting, especially for TCA, you have to wait. Avoid repeated passes without assessing what is happening to the skin. Use means of application that works better for you. For example, you may be more used to employ gauze or Q-tips, and some people employ 1, 2, 3, or 3 Q-tips in order to apply some more. Begin with the forehead and wait to see how the skin reacts, and then move to the rest of the face, and decide if you're going to give your patient any pre-pill skin preparation. The contraindications, pregnancy and lactation used to be contraindications for chemical pills. Now that we have studies that show us that certain chemical agents can be safely used throughout the pregnancy, and we could give a whole lecture for that. But active bacterial, viral, and fungal infections should be avoided. Avoid any kind of open wounds of any kind of retinoid dermatitis. Obtain the atomic history regarding photosensitizing drugs, and of course any kind of abnormal scarring, keloid, and atrophy history after lasers or chemical pills done before. The never pill patients, a certain group. Scleroderma used to be an absolute contraindication, but it's not anymore because a chemical pill can actually help. But we have a new rock star, frontal fibrotic alopecia. We have to pay attention at our patient's hairline, and of course avoid pilling any patient that you are suspicious of FFA. Pilling needs smart-friendly patients. Again, you have to love them. We're going to spend a long time with them, so they have to have a very good compliance. Avoid any kind of unstable individuals, because it takes 2 to party for chemical pills. You are both responsible for the results, and make sure that they have realistic expectations. Thank you.